really a big thanks to Dr. Mucci and Dr. Hamid for organizing this very important seminar, really to pick upon some of the challenges in telemedicine, but mostly how telemedicine has transformed our public health response during COVID. And I'll also provide some insights on what the future for telemedicine holds beyond the current pandemic. And as healthcare providers, as health systems, on a leadership level, what are the frameworks that we can look forward to build capacity in developed world, but also in the developing countries where the burden of the disease, the pandemic has been enormous. So I just want to give you a very warm welcome to everyone, including Michelle, who is a patient advocate, and and sincere thanks to Viviana and Dr. Hamid for organizing this. Well, as you can see, the first part of this presentation is that to give you a brief introduction of where I am based. So I'm based in the Southern Hemisphere. It's what you call in the upper north as down under. So it's in Sydney. So we're still the down under, but somehow the Australia has been quite successful in mitigating the effects of COVID-19. As you could have seen, that we have very limited cases. Even New South Wales and Victoria has thankfully also had a bit of a positive run in a couple of days. So so it's very pleased to know that the health systems have managed to respond very favorably in this country. More so, at the beginning of the pandemic, a group of physicians and researchers around the world, we all got together because we were concerned about enormous mortality and morbidity among the physicians, the frontline healthcare workers who were dying because of tending to patients with COVID-19. And as you've seen in the reports from America, from Europe, especially in Italy, where Viviana comes from, has been enormous. We had a huge toll of patients and the healthcare providers, physicians in their prime of their service have taken a big toll. Many of those physicians were unable to even be given a proper funeral. So it's been a major public health concern and emotional burden on those, what we call a moral injury to healthcare workers. But beyond that, the health systems has taken a big toll. So with that in mind, we, with some friends across the world, we set up an international consortium to really drive a policy-based debate on how do we best mitigate the effects of a COVID-19 pandemic, and as a collaborative platform, which is open access, where we are collaborating on really platforms which are available publicly, and not really compromised with any additional funding from the known sources. So really, passionate physicians and researchers who really wanted to make a change in their capacity, we all came together, and that's where the Reprogram consortium was born. So this particular slide kind of takes you to the enormity of the impact the COVID-19 has seen. And this is a heat map, which comes from the Johns Hopkins dashboard. And as you can see that every bird across the entire Southern and Northern Hemisphere has been impacted because of this particular pandemic. And the global death toll at present is more than 1 million. It's almost 1.2 million across the world. And of course, the number of cases around the world has crossed 46 million. So it's definitely a pandemic of a scale which we haven't seen since the emergence of the H5N1 or the Spanish flu 100 years ago. So so just want to acknowledge that this has impacted every geopolitical areas and coordinates, as you can see, North America, Europe, the toll in Brazil, and now in India, and of course across the world has been enormous. So with that in mind, I'll take you to the next slide, and this particular is really very close to my heart, and I really want to bring it to your knowledge. It's So Elena Pagliarini, which is, she was an ED physician based out of Italy. And she shared this particular selfie of her, where she has been working 10 hours continuously, tending to patients with COVID-19. And it became a symbol of what public health systems in Italy was suffering from. And it was widely shared on social media and became a kind of a public statement on behalf of the healthcare workers and what they were going through. So she is, as you can see, is really fatigued, tired, and that's what the public health system in Italy was like. The European health system was under enormous burden, and same as you can appreciate and happened in Spain and the neighboring countries. So the pandemic has definitely taken a big toll across the length and breadth of Europe and across in the northern hemisphere as well. Now, if I were, so that brought the kind of, you know, the really the sincerity in the part of all the stakeholders in this particular consortium to really think about a policy-driven understanding of where the telemedicine is today in terms of our response to COVID-19, and what are the policy directions that we can take which will drive our debate for future in coming decades. And as you can see, that we had a very broad portfolio of people coming from all around the world. And I just want to acknowledge Viviana, because she brought very interesting perspectives from Italy, but the collaborators actually came from all different parts, including from United States, America, Canada, UK, Spain, Kazakhstan in Central Asia, across the South Asia, Australia, and many of the stakeholders from Africa were also represented in the consortium. So we really wanted to have that diversity in thought and diversity of experience in bringing that set of opinion leaders who can really reflect on the acute challenges that they're facing in their healthcare systems. And then from there, really derive some policy-based directions that can help build capacity for future. In the meantime, we were also working on reaching out to the governments in the local municipal corporations and specific individual governments to ensure that some of these policy directions that we are coming forward to, that we can collaborate with them very closely to ensure these policy directions can actually be embedded in their health systems, not just on a local level, but actually on a national and then on a broader geopolitical level. And I'll take you through some of the success stories coming from these policy directions that we have driven. Now, as you probably know that, you know, the emergence of the COVID-19 coronavirus disease virus started towards the end of 2019, and we have been able to distinguish that this particular virus came from a province, Wuhan, in the People's Republic of China. The World Health Organization acknowledged that this particular virus has now caused a pandemic, and that the official notification came on March 11th, 2020. Now, in terms of the acute effects of the pandemic, that there were difficulties in ensuring the continuity of care, because as you know, the health systems were now being reconfigured to address the acute needs of patients who are coming with COVID-19. But then we also have the burden to look after those patients who have other chronic diseases. Those patients don't just disappear. And the patients with, especially from my interest as in vascular neurology, where, you know, the acute neurological presentations such as a stroke, traumatic brain injury, many of these patients, we noticed there was an initial decline in the presentation, not necessarily meaning that the stroke has actually decreased in the period of time. It actually reflected that patients are probably scared or to access the nearest healthcare facilities. And you know, building on that, you know, there was an international effort by a lot of physicians around the world to really increase awareness among patients that, you know, despite COVID-19, we must bring in a more holistic understanding that the normal acute neurological presentations or cerebrovascular disorders don't just disappear. And if you're witnessing a symptom such as drooping or weakness in facial muscles or etc., then you must present to the nearest comprehensive stroke center and avail the treatment options that are available for these patients. Now, we all acknowledge that the COVID-19 has become a global pandemic, which has, and the response to this global pandemic really depends on how do we best deliver the care to those patients who are affected with COVID-19, but also those patients who probably are not, but are at high risk of infection. There were challenges associated with the preparedness of health systems, and I'll take you through some of the policy barriers that we have found across these countries. So we looked at some of the major challenges of telemedicine implementation across various countries in Middle East, in Asia, in North America, and we found there are specific challenges which are particularly barriers to how the health systems responded during the COVID-19. Unless we don't address those challenges or those barriers, we will be vastly limited in our response in future, especially in maintaining continuity of care at this moment. Now, as you can see, that access to telemedicine has now become increasingly crucial, and our efforts to rectify how these disparities in telemedicine uptake it will be critical in our response to COVID-19 in the coming months, and of course beyond that, and how we address the long-term effects of COVID-19. And most importantly, very close to my heart, is that the telemedicine does have a vital role to play in low and middle income countries where there's a huge disparity in access to care, let alone during COVID-19, but beyond the COVID-19, where not just the number of physicians per patient ratio are very dismal, but also the health systems are very poorly developed and designed to address infectious disease outbreak, let alone looking after patients with chronic diseases. So those acute effects have become more exacerbated, more visible in these times. And I think that's probably one of those lessons that we are taking. Now, for this particular collaborative consortium piece, we really followed the WHO and the Pan American World Health Organization HAT model, which was really to ask these questions. And those questions were that, is there a national telemedicine framework before COVID-19 in that particular country? So all the countries we analyzed, we look at these, basically 5 policy-based questions: whether the telemedicine framework actually existed in those countries, and what stage that framework was. Was it at an initial stage, or was it properly mature, or was it an implementation stage? And what are the gaps in the telemedicine implementation that these countries suffered during the COVID-19? Now, most importantly, we also asked that what telemedicine specific policy changes that have been incorporated since the advent of COVID-19, and what could be potentially be done to improve the telemedicine implementation in the future in those particular countries or regions. So really are compelling questions to identify the gaps, which is quite commonly used across other sectors in the healthcare and beyond. Now, this particular slide kind of gives a very holistic overview of some of the broader answers that we got from looking at those 5 questions I've just talked about. We really, you can go into the paper to read more about the detail for individual countries, but more specifically, in terms of the regional factors for telemedicine network, we found that the gaps analysis revealed that there are existing framework issues. Many of the frameworks in these countries are not properly developed. Some of them are more mature in probably North America and in some parts of Europe. But even in Europe, there are a lot of variations across structural and otherwise variations across the Northern Europe and then in the Southeastern Europe. And the gaps in the telemedicine frameworks are quite acute. There are infrastructure issues that we need to address. And of course, there are more issues pertinent to patient payment and insurance structure, which, as you know, which is a huge problem in developing countries. And of course, also not to take away the problems that we have in the developed countries as well. Now, there are particular population-specific, community-specific barriers that we found, and these are more around the language issue. So there's a lot of a gap in the digital literacy and lack of language, which is understandable to the target populations. So many of the telemedicine frameworks that have been developed are probably more targeted to English-speaking countries. And there was more need for designing and developing culturally appropriate and language-enabled platforms which can be accessed by people who don't really necessarily speak the language that we do. Now, they were more about the lack of educational needs. So probably, there was varying degree of awareness about health promotion and some of those public health measures that these populations should adhere to during the COVID-19 and beyond, such as vaccination awareness, etc. And then in terms of the back end of the telemedicine framework, which is more to do with physician capacity. So there were professional development requirements that needed further scaling up, proper definitions of what capacity individual colleges, such as specialty in pediatrics, neurology, so on and so forth, can incorporate to give clear-cut guidelines of what can be done across on telemedicine and then in other subspecialties. There's an important barrier that we thought that must highlight here is the governance and oversight, which is probably more acute in the developing and underdeveloped countries, where there's a big problem with credentialing, understanding which clinicians are accessing the patients and across the jurisdictions. So some of these issues were quite acute, and the governments didn't have a proper framework, in the ministries didn't have a proper framework to establish these important issues in telemedicine. There was issues with oversight of health system and providers, and more about patient-reported outcomes. As you know, that your technology is only as good as how patients conceive and respond in accessing these technologies. The quality standards were quite variable. Access to specialist care and maintaining that those specialist care is available during the COVID-19 pandemic. There was a lot of shortfall in appropriate access. The compliance with the local, state, or federal regulatory requirements, and the privacy issues, which is of course, in America, there was a laxing of the requirements in terms of privacy for the COVID-19, and of course, some states opened up some of those barriers. But of course, to look beyond COVID-19, how could these issues be appropriately handled? That needs a more regional cooperation rather than a more jurisdiction-specific considerations. And there needs to be a more homogeneous agreement between different jurisdictions to agree on some of these tenets across the spectrum. Now, in terms of the payment and sustainability, I think there was also issues associated with the streamlined payment gateways, and that is probably was more acute in developing countries, where individual providers are reaching out to patients, helping out these patients, but and probably not paid in most of these situations, and to ensure that those issues of sustainability and capacity needs to be addressed is very important. Now, what kind of framework should we look at, should we build for a post-COVID-19 era, and how that will act as an enabler to improve healthcare access, equity, treatment quality, and building health systems capacity and the resilience, such as, during an infection outbreak, we are prepared enough to address some of these acute challenges, and whether these technologies and platforms are cost effective, and whether there is appropriate healthcare resource allocation across this, and whether these systems are enabled and built around, beyond the acute needs, and are able to also define in a very linear fashion how the disease preventive and the collective health strategies are looked after. So really having a more holistic overview, in addition to having the understanding of how to address them acutely. Now, some of the recommendations that we came forward with, that we must have an action plan centered around a global effort to integrate telemedicine into public health response to disease outbreaks and such as COVID-19. And embedding telemedicine as an integral part of national and international guidelines are so important. Many of those guidelines are missing telemedicine from how we respond to these health systems. And that should be really embedded into how we design a disaster preparedness response, and especially in those countries where health systems are really compromised. Setting international standards of interoperability. The key word is interoperability, that the platforms that are developed, the open access platforms that we develop, could be used in Estonia, or it could be used in India, or it could be used in Australia, and they are interoperable so that we could really leverage the data sharing that could inform further that what particular technologies and otherwise are more effective in particular situations and the disease conditions. Now, I'm a big advocate for open platforms, and I think open platforms really is important for building capacity in resource limited settings where we don't really have the financial wherewithal to support the health infrastructure. And issues such as connectivity has really been highlighted in those countries. And really to untangle telemedicine and make sure that these are accessible in remote areas, we also need to work on legislative requirements to freeing up some legislative requirements, but also to have a very robust governance framework. So we have an oversight on how data sharing and other things are being implemented in these jurisdictions. The digital literacy and language is a key important barrier. And specifically when we were looking at the telemedicine implementation in Latin America, we found that these barriers were quite prominent. Also in other pockets in the Southeast Asia, where these particular platforms, so there have been some innovative platforms that have come up, but still the interoperability is a question, whether that can be used across different pockets and even in these countries. Now, the question is, how do we look beyond COVID-19? And some recommendations that we have made in the policy piece, but also is quite pertinent to our debate today, that we really believe that regional efforts such as Pan-European initiative should be explored around appropriate regulation and governance frameworks once the COVID-19 period ends. And as I've just discussed, with adequate reinforcement, built around technology and telemedicine, we can create a safety net of public health response to an outbreak where, because our normal hospital system, the in-hospital systems are compromised. Many of them are being repurposed to look after COVID-19 patients. That's why telemedicine will act as a safety net to look after those patients who probably can't access these conventional healthcare during this time. But also it is important to look after those marginalized populations, such as those populations who are living in, people coming from, don't have a documented migrant status, or people with refugee status, et cetera, et cetera. So really those, for them, telemedicine could act as a safety net. I'll share some experiences of how we have tackled in supporting some of these patients across the developing countries. Our focus on telemedicine must shift towards developing and underdeveloped nations, which carry a disproportionate burden of not just being a vulnerable communities, but also a higher burden of cardiovascular disease and some of the leading causes of morbidity and mortality in the world. So building capacity in these countries is an interest to us, and not just in the developed world. Building on that particular platform, we further explored some of those specialty-specific questions which were identified in the first, but really go into details about where we can support cardiology, neurology, pediatrics, et cetera, et cetera. And some of these questions we have addressed in this particular piece. As you can see that telemedicine has been explored across all specialties by now. So telecardiology, teleneurology, and many of them have shown that they are quite effective in reducing the average patient time through from the admission to discharge, in physician-rated quality of life, greater turnover, ensuring that these technologies have also helped reduce hospitalization in patients, especially patients presenting with cardiac events or acute neurocardiovascular events. And overall, better streamlined inter-hospital transfer, improved quality of care for patients with chronic diseases or on palliative care. So across the spectrum, as you can see, there was an understanding that telemedicine is improving subspecialty care, not just in cardiology, not just in neurology, but across all disciplines, in patients with bulbar or respiratory weaknesses, patients on palliative care, patients with mental health. Mental health has really revolutionized in last decade, but supporting patients and healthcare workers alike in these troubled times where they are suffering enormous burden, not just because of moral injuries, but also the fatigue and looking after these patients takes a huge amount of emotional toll on these healthcare providers. And telemedicine has really proved efficacious in these subspecialty settings. So we proposed that based on these, we can really have a streamlined agreement across the specialties of what could be done and what could not be done across the telemedicine consultation. Of course, the individual barriers apply, but holistically speaking, some of the important issues here are the requirements of what is important across cardiology, across neurology, and things that we can agree upon are that we must have culturally appropriate infrastructure, that your infrastructure telemedicine platform that you use, whether it's a private vendor or a public vendor, it must be culturally appropriate. Or we have resources that during the consultation, we can provide these patients with appropriate and targeted consultation. Regulatory oversight, compliance with HIPAA and privacy compliance are also important. And furthermore, as you know, that electronic medical records are now very much part of our public health systems and otherwise. We must have systems where we can integrate the existing telemedicine technologies with electronic health records, apps, Internet of Things and monitoring devices, so that the amount of that data that would spin out from these technologies can further guide how best we can implement telemedicine for future. And of course, the very important part is the sustainability part. How do we ensure that every bird, every human being is covered under the insurance provisions, and whether the best of healthcare is available to all of them. And that's very important to ensure that the government and the private payers are all on board to support their care and then beyond during COVID-19 and after, to look after the effects that may or may not exist after COVID-19. So, and we can really leverage all different dimensions of technologies, text, audio, and video, and that would really need a collaboration between patients and healthcare providers. And so we proposed a workflow, which was really about understanding, taking the patient and going all the way to the bottom and really tailoring the treatment and triage algorithm to the patient, depending on the acute or chronic needs the patient has. And of course, going on, building on what are the pharmacy medications that can be dispensed on telemedicine, or probably would need a more inpatient, one-to-one, person-to-person consultation. So that those specific considerations need to be understood in more detail. Now, for specific indications for specialities, these are some important observations that we make in this particular recommendation piece, that the physicians, we must be able to assess mental status, visual, cognitive, or auditory deficits. And if it could not be done or established during a consultation, then having appropriate person who can enable that consultation is important. And of course, we must acknowledge that some of those, especially in neurology, not all of those dimensions can be appropriately assessed, and that we would be wise enough to get the patient to come for inpatient consultation. Motor examinations, can be conducted with the aid of a caregiver. Probably it need more training, and the caregivers can be trained over time. And nurse practitioners can probably get more involved in training the caregivers to help ascertain the understanding of strength, the tone, reflexes, dermatome, sensation, and probably the cerebral function. So probably more training we get them on board and get them be more prepared to support the telemedicine implementation in those difficult settings. Consent must be taken from both the patient and also the assister. The person who is assisting the examination should also provide consent, and that is important to ensure that the compliance and also, most importantly, ethical communication is maintained during the consultation. Special considerations will apply to patients with specific conditions, including pediatric patients and those with intellectual disability. And detailed examination, as was just mentioned, in terms of tone and strength and comprehensive eye examination will be limited, and that would need accessories. Probably we could leverage some of the technologies that are available, and I'll talk about some of those technologies in the next slides. But overall, if there is an ambiguity in your diagnosis, you must acknowledge it as a limitation in your report, so that some of those liability issues can be looked after. But beyond that, building the the telemedicine capacity beyond COVID-19. I'll just take this in a poignant photo from Brazil, where the healthcare workers and the people are taking the coffins on a mass scale for a burial, where their next of kin are not available at the site of the funeral because of the restrictions imposed. So, so we must acknowledge that the long-term effects of the COVID-19 will be there and will linger on beyond this time, and that would mean that we will have to support these patients. We need to train physicians and otherwise a next generation of medical students and the trainees to be understanding that COVID-19 could be one of the risk factors, and those precipitating effects will linger on beyond this pandemic. And as I said, that telemedicine to act as a safety net is so critical. Now, when we were discussing about these limitations on a policy-based issues, on a subspecialty specific limitations, I was discussing about how do we improve our organizational framework. So as you know, so to give you an instance of what framework I'm talking about, in an acute stroke setting, when a patient has developing acute stroke symptoms, and a patient wants to reach the nearest, patient or patient next of kin, takes the patient to a nearest comprehensive stroke center. Some of the barriers that the patient are that the paramedic goes to take the initial notes, assesses the patient, whether there's what we call the fast-based symptomology is available, and if the patient is developing acute stroke, then the patient should be taken to the nearest primary stroke center or a comprehensive stroke center. And then, depending on the symptoms and the severity of the symptoms, we can assess whether the patient would need intravenous thrombolysis or endovascular thrombectomy. And as we have seen that 2015 onwards, the vascular neurology has dramatically changed. So we can now provide a treatment which has dramatically improved patient quality and mobility after the treatment is received by these patients. Then how do we ensure that the telemedicine, the frameworks the organizational frameworks that we use are being optimized? And what are the technologies that could be leveraged to optimize the framework, the organizational frameworks? So in that context, artificial intelligence and robotics could be used as an accessory to improve how do we connect the patient to the right healthcare providers, and so on and so forth. I'll take you some examples furthermore. And furthermore, building the technologies in a way that they are integrated with electronic health records, the Internet of Things, the computers, cloud computing, so on and so forth, that the data can further improve the intelligence around that, these healthcare providers are more appropriate for this particular patient or in that particular location, so on and so forth. So those intelligence around what is more optimal for a patient is important. Now, if you look at traditional organizational structures that have been used in medicine, so a patient in Rome, in a northern part of Rome, suffers a stroke and is brought into the nearest comprehensive stroke center. Now, that routing of patient takes through different routes depending on what the model is being used in that particular country. What happens in those settings, we call it the hub and spoke model, which is, if you look at, you'll appreciate this particular C figure. So at the hub is a comprehensive stroke center, and these small little spokes around the hub are these primary stroke centers. So a patient comes into the spoke, gets intravenous thrombolysis assessed by an ED physician or a stroke physician, and if the patient is within a particular time window, the patient is referred to the hub, where they can avail endovascular thrombectomy, where interventionists will pull the clot out of the stroke patients. Now, these frameworks have their limitations. So there are limitations about how do you route patients, there are limitations about system inefficiencies, and those have been extensively reported in literature. So there are other frameworks that have been proposed, the specialized, the Dendelian, and the holistic frameworks. Unfortunately, these frameworks have been have their limitations, which has been one of the biggest barriers on how do we create a health system that is optimized for the best of care, of patient care and delivery. So in this particular piece, we have proposed an artificial intelligence enabled telemedicine framework. And what does it does? That it actually builds on the intelligence from the existing information, the data, and then it connects the geospatial informations and thinks about and gives a decision tree model to that which patient will be best suited for which particular provider, depending on harnessing the data that it reads over time, so that it connects the right patient to the right provider, so that the patient will have a best of care in that particular time. Now, building on this particular repository of knowledge, we also had an experience on really implementing some of those ideas that we discussed in a real world setting. So we collaborated with some primary care physicians in the developing countries, and they were referring patients on the DEES telemedicine framework on patients who were home quarantined. These are patients with COVID-19. The entire family is COVID-19 positive, and the healthcare systems locally don't have a capacity anymore to take these patients. Either they can be, sit at home and probably be more morbid and suffer more mortality. So to support these health systems, we had a pool of physicians coming together remotely and supporting the best of care, and of course considering that what is the most cost-effective ways. So now to that end, I just want to end with some few thoughts about the consortium that we developed. We call it Reprogram. It's developing the pandemic resilience and beyond. So really building our systems for preparedness for future. And as I've said to you before, the tenet of this particular platform was that really working towards leadership in global health, built around human rights, social justice, and peace. And the premise and the inspiration was that many of the healthcare workers have unfortunately suffered death after tending to patients, especially in North America, in Europe, and in South Asia. And that has created further burden on health systems. And also builds to our understanding that the planetary health that we live in can be challenged with these infectious outbreaks, public health emergencies, so on and so forth. And that's why we need a more whole of society approach, which is built upon the social medicine aspects of medicine, which is to looking person as a whole and society as a whole and targeting those elements and together. We have been quite successful in terms of implementing our guidelines. So the guidelines that we published in stroke has been now uptaken by the American Health Association as in a course to guide physicians how to look after patients with stroke and acute neurological injuries. We've given a portfolio of work of how to improve more access to personal protective equipments, but also adherence among the acute care physicians in these settings. I'm also pleased to share with you that one of the guidelines that we've developed, which really builds upon a cost-effective way of treating these patients, have also been uptaken by World Health Organization, which really targets an important pathway, the cytokine storm, which we see in most of these severe patients. and has been, which we believe is a leading cause of mortality in the subset of patients, and really targeting some of the existing knowledge, a case-based approach to help and support these patients. And it's been widely shared. We had about 20,000 shares across the world. It's one of the top 2% of articles published on Frontiers. So we are very glad that it's being implemented, and a lot of collaboration happening in low resource settings built around telemedicine and these platforms. So just to conceptualize it, this is a slide which I really share because I truly believe that leadership is critical, and inclusive leadership can build more partnerships. And partnerships should hinge around inclusion, diversity, and intersectionality. Acknowledging that leadership comes from all different parts of the world, bringing a talent pool that acknowledges that the people from Africa, from Middle East, from North America are at par, if not less, to contribute their knowledge and expertise in building how we should prepare ourselves and address the challenges that these pandemic come up with. And overall, hopefully this will improve health outcomes of patients and communities. Just with that, I just want to acknowledge the telemedicine subcommittee members. We had Alma Notazina, Sian Bradley, Vijay Chatu from Canada, Viviana Mucci, as you heard, and Sebastian from Ireland, Simon Israel Korn, a great friend of mine from Israel, Philippines, Jason Alcapa, Abba, and Shana Pandya from USA, Canada, and Star was a nurse from Pennsylvania, and Ashish Satreja is from Mount Sinai Hospital, and Mashiak, who is a cardiologist based out of Poland, but is also served in Undersecretary with the European Parliament, and Daniel Ray from the FAR Institute of Informatics at University College London. So very comprehensive expertise, precipitating. With that particular thought, I will leave you with this slide from Italy, where, as you can see, the priest is blessing the coffins of the deceased patients who are unable to, the kith and kin, the family members unable to give the proper funeral, but is being attended by the priest because of the restrictions that are imposed. It's a very sobering moment for what we have encountered in the last 10 months, probably an event of our lifetime, and that is a sober reminder. With the final slide, I'll just want to bring your notice to this particular slide from the southern New South Wales, or rather the Hunter part of New South Wales, the koalas, as you know. Before the COVID-19, we had this huge fire outbreak in the rural New South Wales, which wiped out an entire population of koalas. And a journalist took this photo of koalas hugging together. And I think we have got so much to learn from them, that the compassion and togetherness and collaboration is key in how we respond to, and of course we can't stop these events to happen, but how we respond is so critical. So thank you so much for listening to this presentation. I really look forward to more further discussions with our panel, and I hope it was useful in building that the narrative of what are the challenges that we face at this time and how do we address these challenges in future. Thank you.
Thank you very much, Sonia. You're the moderator, Vivian.
Yeah, no, thank you so much for the very nice presentation, very comprehensive, and I could not be happier than hearing someone that wants to really share and implement a global vision, which I truly think is what we need right now on so many different levels. So it was really nice to also hear it from someone on the other side of the globe, let's say. So